welcome to this MedEClasses lecture series on delayed puberty in girls. And this is part of our initiative, a monthly initiative in which we propose to cover the entirety of pediatric endocrinology from a pediatrician and pediatric trainee perspective over the next 36 months. I'm pleased to be joined by Dr. Vibha, who is a consultant in pediatric endocrinology at Regency Health, and Dr. Dhwani, who is a fellow with us at Regency Center for Diabetes, Endocrinology, and Research. So this is a very, very important topic. And what are the key things, Dr. Vibha, you have to understand in terms of when you are evaluating a girl with delayed puberty compared to boys with delayed puberty?
In compared to the boys, the presentation, the cause of the delayed puberty in girls is mostly physiological, is not physiological in comparison to boys. So we have to firstly rule out the systemic causes and other pathogenic causes or the organic causes in comparison to boys.
So although we have got lesser number of girls who come to us with delayed puberty, we need to be more worried about that in that perspective. So Dhwani, in your experience, what are the common presentations or common causes of delayed puberty of girls?
So again, as ma'am has mentioned that when you have a girl with delayed puberty, you have to be wary of it being a pathological cause. However, we've seen that about 1/3 of these children are actually physiological and self-limited delay of puberty. However, the most common causes that we encounter are probably hypothyroidism, Turner syndrome that we commonly see in our day-to-day clinical practice.
So celiac, hypothyroidism, Turner syndrome, these will be a very, very common. So we have this 13-year-old girl who had presented to us a few years ago with concern for delayed puberty. She had stage 1 breast development and stage 1 pubic hair development. So parents were concerned that she was not having puberty. She was short for the age, weight was reasonable, and somebody had done a workup which showed a low level of LH and FSH. To compound the matter further, ultrasound had been done by the referring physician who found an absent uterus. Now, this was a very devastating scenario for the parents. They were very concerned about the puberty, breast not being there, and ultrasound showing an absent uterus, which was an entirely disastrous scenario from that regards. But what we need to understand is that 13 years is just the edge in terms of the time when puberty should happen. And in this scenario, clearly, we need to understand that when the breast is developing, the uterus will take time to develop. And at breast stage 1, we can often miss a uterus on a transabdominal scan. So this case really highlights the importance of not doing unnecessary workup like ultrasound. And this case better would have been to wait and watch. And this is what we did. And the girl had a normal outcome subsequently. The second scenario was a 14-year-old girl with delayed puberty. Now, this is from a different perspective and dynamics. She had presented with stage 2 development with pubic hair stage 3. So what looked like that she had some development to begin with. This is what the parents said. And then the development had stopped for the last year or so. Again, the same thing was found. LH was 0.1 and FSH was 0.1. And people thought that, okay, like the first case, better to wait and watch. This was labeled as constitutional delay. Now, as I'll talk subsequently that when somebody has a stalled puberty, it has got an entirely different connotation as compared to a classical case of delayed puberty in girls. And in this case, we should be worried about our underlying cause, which was missed. And she presented later with seizures and glioma. So there seems to be a quick balance with regards to not doing unnecessary workup in delayed puberty on the one hand, like in the first case, but also to not miss a cause, which is very important. This is what we'll try to focus over the next hour or so, is to develop clinical pointers to suggest pathology and do a reasonable amount of workup without overdoing it to identify the cause from that perspective. Now, delayed puberty, as we discussed, is common in girls. Approximately 2.5% of all girls have delayed puberty. As Dhwani was talking about, 30% to 40% may be physiological, but we can have other pathologies like hypogonadotropic hypogonadism, less common as compared to boys. Functional causes like malnutrition, systemic illnesses, more common in girls compared to boys. And of course, hypogonadotropic hypogonadism with Turner syndrome leading the list is definitely common in that regards. So our role is to not unduly investigate these 30 to 40% with physiological causes, but not miss these 60-70% who have a pathological cause in that regards. all of you should go and have a look at our website learning.growsociety.in, which has got a lot of resources with related to pediatric endocrinology, including a number of video lectures which are available and courses in terms of that. We have our e-learning platform on YouTube, which has got a large number of videos as well. And we have got validated courses in terms of pediatric endocrinology, including a full hybrid fellowship program of a 2-year program, specific pediatric endocrinology course for postgraduates, which is also available. We have got a full spectrum of books ranging from pediatric endocrinology protocols, which guide the pediatricians and pediatric trainees for basic workup, to basic pediatric endocrinology, which is covering pathophysiology as well, and advanced pediatric endocrinology covering the entirety of pediatric endocrinology. Our mobile application, which I'll touch base later, is one tool which helps in terms of point of care management in that perspective. So today we're going to focus on delayed puberty in girls. We already recently had series on precocious puberty in boys and girls. That's available as part of our YouTube channel, and you can go and have a look at it. I am joined, as discussed, by Dr. Vibha and Dr. Dhwani, who will be focusing about different aspects of delayed puberty evaluation from that regards. What we can do theoretically is we can give estrogen, of course, to induce puberty, which is the most likely treatment. We can think of gonadotropin treatment in somebody who has a hypogonadotropic hypogonadism. There are studies which have looked into GnRH pump-based therapy and the use of kisspeptin, but predominantly we will focus on estrogen and gonadotropin for fertility in hypogonadotropic hypogonadism. If somebody has an ovarian problem, we of course can only give estrogen. In certain scenarios, specific therapy may be possible. For hyperprolactinemia, they will respond wonderfully to D2 receptor agonist. If there is a prolactinoma, macroprolactinoma, long-term treatment, microprolactinoma, up to 2 years treatment is required. Anorexia nervosa, we have to do a nutritional rehabilitation. Once the weight becomes more, they will have increase in fat and the periods may happen. Celiac disease respond dramatically to gluten-free diet. Systemic disease, specific treatment is required. Now, estrogen, the route is very important. We have an option of either giving estrogen via the oral route, wherein it goes to the liver and then reaches the circulation, or we give a topical scenario in which we just apply. So when we give orally, it is going to the liver. It is affecting IGF-1 production, resulting in lower level of IGF-1, increased level of protein C, resulting in thrombotic tendencies, increased lipase, resulting in dyslipidemia. So oral preparation may have a lot of complications in that regard. Transdermal preparation, on the other hand, will directly result in the delivery of estrogen to the blood. They will not have an effect on IGF-1, thrombosis, dyslipidemia, or hypertension. These are the agents of choice, but they are not readily available and are expensive in that regards. So we have an option of transdermal versus the most commonly we use is 17-beta estradiol. The dose is 2 milligram per kg per day. We have to start from a very, very low dose. The effect on IGF-1 is, of course, more with 17-beta along with hypertension and thrombosis risk, as we have discussed in that perspective. So the estrogen preparation, which was earlier used, was ethinyl estradiol. The adult dose typically is around 10 to 20 microgram per day, and typically we should start from around 10% dose. But this is a very strong preparation. We should better avoid ethinyl estradiol. What we use is ethinyl estradiol valerate. In that, we start off with 0.25 milligram and then build up to adult dose of 2 milligram over a 2-year period with a physiological development. Transdermal estrogen, the options are to start off with 3 to 7 microgram per day by cutting the patches and applying that on alternate days to begin with, and then gradually build up to the adult dose. The benefit of transdermal estrogen is that it doesn't have an effect on IGF-1. In girls who have constitutional delay of puberty and growth, if they are getting too late, we may push the puberty by giving a small dose of estrogen, like we give testosterone in boys, 0.25 to 0.5 milligram daily for 3 to 6 months. And this often kickstarts the puberty in that scenario. Those who have a permanent hypogonadotropic hypogonadism or hypergonadotropic hypogonadism, we start with 0.25, build up over a 2-year period to a 2 milligram dose, and then only considers adding progesterone. If a progesterone is given at an early stage, it compromises the breast and uterine development and should therefore be avoided. The fertility option in hypo is gonadotropin, which we'll discuss a bit later. For hypergonadotropic hypogonadism, the ovarian problem, we can think of a oocyte donation. Progesterone should be added only around 2 to 2.5 years after the onset of pubertal induction, and we could give it or the periods have happened. The options are medroxyprogesterone or micronized progesterone. Micronized progesterone are preferred, but they are more expensive in that regards. They should only be given either at vaginal bleeding or the endometrial thickness is more than 5 mm, because too early progesterone prunes the breast development and the uterine development as discussed. So for self-limited delayed puberty, start around 13 years and a bone age above 12 years. Start with estradiol valerate at 0.25 to 5 milligram for 6 months and gradually look for pubertal response, and you will find increase in LH and breast development, and this will be usually a process which will improve. For permanent HH, we start off around again at 12 years of age. The protocol is estradiol valerate 0.25 milligrams, increased by 0.25 every 6 months to adult dose of 2 milligram by 2 to 2.5 years. The follow-up will be to look at growth, progesterone if there is a bleeding or the endometrial thickness is more than 5 mm. Breast size, however, will remain compromised with multiple pituitary hormone deficiency. We typically have periods by around 2 to 2.5 years, and we have to monitor blood pressure in that scenario. For hypergonadotropic hypogonadism, the options are oocyte extraction and donation, but often by the time they come to us, the oocyte is already not there. So most girls with Turner syndrome don't have that option. Oocyte donation therefore becomes an option, and oocyte extraction can be done after 12 years, but it's an invasive procedure. The future direction, of course, is ovarian transplant and stem cell.